This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Ariana Parks, physical therapist and your host, and today I bring you my conversation with Professor Peter O'Sullivan, where we delve into cognitive functional therapy. In our discussion, Professor O'Sullivan will cover what cognitive functional therapy is and its three key elements, how he screens his patients and performs physical examinations, how he addresses psychosocial and lifestyle factors and when he refers patients out, how to change cognition and integrate CFT with other approaches, how he structures his training to help other clinicians develop skills in CFT, and much more. Dr. Peter O'Sullivan is a professor at Curtin University and a specialist musculoskeletal physiotherapist, renowned globally for his work in musculoskeletal pain disorders. He and his team developed cognitive functional therapy for disabling low back pain, a treatment proven effective in numerous trials, including a recent landmark study in the Lancet. Professor O'Sullivan has authored over 350 scientific papers, contributed to multiple book chapters, and has spoken at more than 120 conferences. He also consults on musculoskeletal pain disorders. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Sarah Health. Have you heard of remote therapeutic monitoring? Does it sound complicated and hard to implement at your practice? It doesn't have to be. Sarah Health is revolutionizing RTM, making it straightforward for your practice. From easy onboarding to hassle-free billing, they cover it all. Hi Pete, welcome to PT Pro Talk. How are you today?
Good, thanks.
Awesome. So let's get started talking a little bit about yourself and your career for the ones that don't know you yet. I'm pretty sure everybody knows you, but...
No, definitely not. I grew up in New Zealand and did my PT training in the south of New Zealand many years ago, and really kind of hit a point where did all these workshops and knew lots of techniques, and I was treating people's symptoms, and I wasn't happy. I was like, I can't keep doing this job. So it was either change or do further study. So I elected to go to Australia and do my postgraduate training in manual therapy, and that kind of opened lots of doors for me, where I started both working in a pain management clinic, which was dealing with very, very, very disabled and distressed people, and in a private practice, which was people coming in where I could manipulate their spines and they'd feel better and walk out. And it was like, wow, these are two really different worlds. There's a world where my hand manual therapy techniques work really well, and there's a world where I can't. It just doesn't make any sense. And that's where, at that point, there was almost no evidence that what I did as a physiotherapist did anything. There was no randomized controlled trials, or very few, demonstrating efficacy of anything we did. So I'm like, maybe if I'm going to keep doing this, I better do some research. So that really pushed me down a research path, and pretty much my career has bridged those two gaps. Like, I still work in clinical practice, and I work as a professor at Curtin University doing research and doing some postgraduate and undergraduate teaching as well. And that's sort of like my journey, of this parallel journey of working in the clinic and working, from a research perspective, to ask clinical questions and to test the dogma that I've been taught, I suppose, as a young physiotherapist, to realize that there was actually very little evidence of anything I'd been taught. And part of our journey, our team's journey, is to test the evidence and go, does it stand up to rigor, scientific rigor? Most of what we have been taught doesn't.
It is crazy how everything we learn in school.
What you think and what's evidence based is two different things.
Yeah. And what we should be learning, we're not learning.
Yeah, exactly. Yeah.
And so would you tell us a little bit about cognitive functional therapy? What is it? How do you define it? Is there a definition for it?
Yeah, so it's something that's evolved over time, really. We realized pretty early I realized pretty early in my clinical career that simply treating signs and symptoms wasn't effective for people who were disabled with pain, and that actually, pain is way more complex. So, I started my career with a very structural biomechanical perspective on pain. That's because there was almost no evidence, and I was relying on the information I've been taught. And then over my career, we just learnt more. We've learnt more through the research we've done. We were looking at, movement patterns, because we were seeing that people with pain move differently than people without pain. And I was looking at through the lens of, there's something biomechanically, structurally wrong with that person. And we realized that actually, a lot of the behaviors that people develop around pain are not a feature of structural instability, but it's a feature of their thoughts and their emotions and beliefs, where they become overprotective. They have the body's pain protective mechanisms. And so, over that period of time, as well as other people's research, there's been this growing evidence that pain is complex. It's really complex. It's linked to, how we respond to pain is linked to our beliefs, our emotions, our behavioral responses, genetics. Is a whole complex range of factors. So based on that, if we want to target pain, we have to target all those things. So, we know that if you have a belief that pain means you're damaged and you need to protect your body, it will drive your behaviors. You'll become more protective and avoidant. That will be often linked to emotions, like you become distressed or you become frightened, or you get down because you can't do the stuff you love. And so this kind of combination of, thoughts, emotions, and behaviors, which have been talked about in the CBT literature for years, around a whole bunch of health disorders. So become targets of treatment. And so if we look at the three key pillars of CFT, one is the making sense of pain, where we don't just teach people pain neuroscience, but we go, tell me your story. Let me understand your story and your lived experience of pain and try to make sense of it through your own story and experiences, and from what we see in the examination, so that we can kind of map it in a personalized way. And the second part is what we call exposure with control, where we take people back to doing the things that they fear, avoid, or that are painful, but we teach them to do it in a less protective and less guarded way, to build confidence in their body to get back to stuff they love. And the third element is around lifestyle change, which we know lifestyle factors, growing evidence around the role of lifestyle factors, that, physical engaging in regular physical activity is like so important for human beings. Good sleep, stress management, healthy diet, those kinds of things we know are hugely pro-inflammatory. Unhealthy lifestyle factors pro-inflammatory, and just like a massive driver to the nervous system. So it kind of combines the making sense, which is you got to understand something to change your behavior. And then the behavioral stuff is really coaching people to build confidence back in their bodies to do stuff that they want to do. And the third element is the lifestyle change. And that are key pillars around changing cognitions, building confidence in the body, which is to lose your fears, and build your self-efficacy. And then the lifestyle stuff is, just creating a healthier ecosystem for people to engage in life with. And there's really good evidence that each of those key elements are really important for effective management of pain problems.
Yeah. And how do you go about changing cognition?
Yeah, good question. Well, sometimes it's purely because people have been given crazy information. And so some people literally are very open to change. They might have been told, oh, you got a degenerate disc, and that means that you can't bend and lift and do normal things. You got to protect your back, and you shouldn't run anymore. And they may not like that idea. They're like, tell me different. I'm happy to change my view. Then there are other people who are really frightened, who are very, very, that becomes part of their identity. I am the guy with the damaged back, with the bad back, and, my disc rotten, and I can feel it go out all the time. And the other people where educating doesn't work very well, where actually you can only change someone's beliefs or cognitions through behavioral experiences. So, for example, if you have a belief that bending and lifting is dangerous for you, but if you work with that patient and demonstrate to them, if you do that in a way that's not as protective and with more confidence and more relaxed, it doesn't cause the thing that you thought. It makes you question your own beliefs. And so there's growing evidence in our work that that probably the most powerful cognitive shifts happen through behavioral experimentation. That is to take people back to the things they thought were going to do them harm and realize it's actually safe. And we know this from other fear literature. If you have a fear of heights, the only way you can overcome it is to really become confident with heights. If you have a fear of flying, you got to fly. If you got a fear of riding a bike, you got to ride a bike. So that's our job, is to take people really gently back into the things that they're frightened of or avoid or think they're going to harm themselves with, and show them that actually it's safe, because movement is good for us. And, in the absence of serious pathology, movement is therapeutic, and people don't believe that. People think, oh no, you got a back problem, you got to protect it, you got to sit straight, you got to brace your core, you got to be careful when you bend. All this stuff we push through society, it's just not evidence-based, and it teaches people that their back's fragile and needs to be protected.
Mm-hmm. So it's almost like the number one, the key element depends on number two. If you're just going to change their cognition, if you help them to build confidence,
100%,
to change those beliefs.
Yeah. And sometimes you do this, you go, so you were telling me before that it was dangerous to bend and lift, and I know we just got you bending and lifting. How did it feel? It's like, it feels great. What does that tell you about how damaged your back is? And I go, well, probably it's not as damaged as I thought. I said, well, that's what your body's telling you. So it stops this argument, because I think we often hear this. It's like, as a clinician, we tell people how it is, and they're like, it backfires often.
Mm-hmm.
It doesn't work well.
Yeah. And we have a lot of approaches that are pain neuroscience education, but they are a lot more, I guess, talking. Maybe I have a wrong perception, but by the things that I read and have studied, it's more like you are trying to educate the patient more in a more, I'm not going to say lecture way, but you are talking to them, trying to show them by words and communicating.
Yeah.
And so that's, how would you say your approach, or the CFT, it's similar or different from those approaches?
Yeah, it's a good question, and we get asked this a lot. I think it's really important for clinicians to understand neuroscience. It's really important for them to realize that pain very often is not a good measure of tissue damage. That's an important thing for clinicians. But I think there are some patients who they want that detail. Others just want to know it's safe and to get on with their life. And so getting on with the life seems to be the key thing. And we, rather than, sitting people down and going through, a lecture, we would say, hey, I'm hearing these things in your story. So I'll give you an example. So a chap I saw recently, he had a life-threatening event where he'd lowered something over a big electric cable. It would have killed him. It was a highly stressful event. He developed acute pain. And then over a period of time, these stress events occurred in his life, what triggered pain. and the pain became so disabling. And his response to pain was to shut down. He saw a surgeon who said, look, mate, you've got, these broken bones in your back, which was pars defects, which is really not a good descriptor. Your back's degenerating. You need to be careful with it. So his life just closed down. But as it closed down, his pain got worse. He became more socially isolated. He became depressed. He became more fearful. We know this is what happens. And then on examination, everything he did was protecting and guarding his back. But what we realized is as we examined him, he started to relax. He started to feel less pain. He started to feel confidence. He started to realize that actually his back was not as damaged as he thought. That then allowed me to sit down with him and go, can I now explain what I hear from your story? That you've had these stress events, you've been told your back is damaged, you need to protect it. But what you've learned today is that actually relaxing and moving naturally and using your body in a normal way gives you pain relief. What does that tell you about your body? He goes, well, it tells me it's safe to move. It tells me that I've been overprotecting. It tells me that I'm not as damaged as I thought I was. So all of a sudden, through that journey, I don't have to sit down and give him a pain neuroscience lecture. I go, this is how you make sense of your own story and your own experience. And I think it's that personalized nature. We know person-centered care is what patients want. And this is what it is. It's a person-centered approach to say, let's make sense of your story. Because we do know from qualitative studies, often people with chronic pain are educated, given neuroscience education, they go, oh, that's kind of interesting, but that's not me. Because they can't personalize it. They can't personalize it and see how those things link to their life. And I think that's the key. So the underpinnings of the understanding are centered around pain neuroscience. Like we need to know that as clinicians so that we don't tell people crazy things. But how we educate people, we tend to do it more through the patient's story and using their own language and aligned to their own health literacy. And, some people, it's just going to go right over their head. If you've got a truck driver, they just want to know if it's safe to, lift stuff up and get on with their life. We don't need to complicate that.
Yeah. And so like when you start your assessment, you just ask that question to the patient.
So with the things we assess, the things we assess are the things they can't do. So typically I'd say, so tell me the things you're struggling with. So for this guy, sitting was a massive issue. He avoided bending and lifting. Because of that, he didn't ride a bike. He would love to paddle on a kite, but he didn't do that because he'd been told he shouldn't. So the only thing he did is walk. And, that was okay, but it's not what he wanted to do in his life. So we're like, so tell me the worst things you could possibly do. It's like, sitting for a period of time, bending, lifting, that'll be my biggest things. And they're the things that are stopping me from living. So I'm like, right, let's look at them. So the examination was to let's look at what you're doing when you sit. Let's look at what you're doing when you're bending and you're lifting. Let's explore those things because they're the things that are important for you. And I think often in clinical practice, we spend too much time doing a whole lot of tests that have got nothing to do with the patient's story. What's important for the patient are the things they can't do or they're struggling to or the things that hurt them. That's what we're interested in.
Mm-hmm. And like when you ask them to start telling their story, then you're looking for a few things they're going to say to decide your next approach, or you're always doing this behavior experiment with everybody?
Yeah, so so the first thing we do is interview somebody and using open questions like, tell me your story. Mm-hmm. Usually they'll start somewhere that's very important for them. And then through that interview, we'll guide them to explore all the things we need to explore, their beliefs around their pain, their experience of pain, the pattern of their pain. We screen for red flags, serious pathology, general health, their social setting, their emotional responses to pain. So it's a very broad, multi-dimensional interview that then leads us into the examination. But of course, the beautiful thing about a behavioral examination is if someone's got, like nerve compression and, radiculopathy, they won't get better when you get them to relax. People with pathology don't feel better when you get them relaxed and move normally. So we're not forcing people to do stuff. We go, hey, let's just check this out. Let's have a look at how you're moving. And, of course, we're cognizant of screening for neurology and making sure we don't miss red flags, because we don't want to tell people it's, safe to move if they've got cord recliner syndrome, or they've got a malignancy or an infection or a fracture. We don't want to do that. But the majority, what we see is not that. The majority sits in this black box of, pain that pathology is just, it may or may not be part of the jigsaw puzzle, but it's not the whole puzzle.
Mm-hmm. And like in the beginning, you said the difference about these two different groups that you used to see in the beginning of your career, right? The ones that you could help and the ones that you couldn't. So like, how do you screen for like those two different groups, the ones that are potentially is going to respond to therapy, manual therapy, the things that we're used to, and the ones that are not?
Yeah, that's pretty straightforward, really, because, I don't know if you use screening tools, but we use screening tools like the Orebro screening tool, which is, it's a multidimensional screening tool. It screens for people's level of pain, disability, their sleep, their anxiety, stress, depression, beliefs. It's a useful screening tool. And people who score high on that have a lot more complexity. People who score low, we have people who've just got aches and pains and they like a rub down and they want to be pushed on, and that's fine, but they're not disabled. They're not people who are out of work who can't do stuff in their life. I think we get caught in our little ecosystem where we think everything we do works because it serves the people we see, but we don't see the lists of people in pain clinics who, I had an email yesterday. This guy's had 60 operations. He's had multiple injections, and now they want him to see me at the end of all that. And it's like, what are we doing in a health system where we're sticking people with drugs, we're sticking them with injections, and that person will have seen a PT at some point in their life, and it didn't work because probably we didn't address the key drivers of that person's pain. So we have to get way better at screening for people and have a bigger toolbox. And that's what, my career, like I'm a manual therapist, I use my hands. But I'm really careful about how I do that. And I'm very clear on my messaging. And I'm very aware that manual therapy can be effective for short-term pain relief for a group of people, but it's not a long-term solution for people's pain and disability.
Yeah. So like you have a good idea when you're seeing the patient because you screen them with the questionnaire first. So the ones
and
that...
you hear their story and you examine them. Yeah. So the person's really disabled and they're very frightened and they're overprotective. We need to take that person on a journey to understand what's going on with them, build confidence back in their body and get back to living again. That's the most important thing. How you get there, it's kind of up to, there are lots of ways to getting there. CFT is just one way, but it's got good evidence behind it.
Yeah. And then do you end up using other tools after you use CFT if you have like a disabled person that you help them overcome their fear of movement, you build confidence, and then you treat them with your PT tools?
What do you mean? What examples?
For example, you have someone that's very afraid of bending, right? Because they think it's going to damage their back. So you help them overcome the fear of bending. But you still see if they have any other normal impairments, range of motion, strengthening. So you still do the rehab side.
Oh yeah, 100%. So the journey bit, so I didn't fully explain that. So once, getting people back to the stuff they love is the key. So what are the barriers to getting back to the stuff they love? So it could be fear in the first place, but they could be just deconditioned and weak and, just need to build fitness and strength. So that would become part of that journey. So it's not like we just go, oh, just relax and move. It's like, no, now we want to get you strong. Now we're going to load you up because you want to be, lifting stuff in the garden, or, a lady yesterday, I want to carry my kid, she wants, that's her goal. Like she had 3 goals. One is carry her child her baby is 7 kilograms, run again. So the program was like, okay, you want to run, you want to carry your kid, and wear high heels, ironically. So it's like, okay, we're gonna target all of those 3 things, and to do that, you need to get strong. You got to be strong in your legs to run. You got to build up your fitness. We're going to do it gradually. If you want to carry your kid, we're going to slowly build up your ability to take load through your back. And if you want to wear high heels, then we're going to practice getting on your tippy toes. So, they become the goals of the patient. And the lovely thing about this approach to work, it's not about our agenda. It's about the patient's agenda. It's like, hey, we're here to support you with your goals.
Mm-hmm. It's almost like you are trying to get all these layers that are on top on the way of the rehab, so then you can actually rehab.
Exactly, yeah. And we often see that, like, it's almost like people go, I want to do this, but I don't know how to get there. It's like bridging the gap. Yeah.
Mm-hmm. And it's like the person needs rehab, but they are so scared.
Yeah,
so
exactly.
afraid of
Or
moving that you're not going to get there.
frightened. Exactly. Yeah, exactly. Yeah. Correct. But the rehab part is part of the program as well. But it's very functional. Part of the lifestyle stuff is if they go, I want to go to the gym. It's like, great, let's go to the gym. But they go, I want to ride a bike. It's like, cool, ride a bike. Like we don't say, oh, you shouldn't ride a bike. You shouldn't do this. Do Pilates, do yoga. Like, it's all good. We're not into one kind of exercise. We know physical activity is really good for people. And the best activity is the one that they will keep doing, the one they love and they'll keep doing.
Yeah. And so that fits on that second key element that you're saying, like the restoration of movement, the rehab portion of the approach.
Yeah. Yeah. Like the lifestyle part is physical activity. But we tend to do it around the person's preference. We don't say you have to do this kind of activity. It's like, hey, what do you like? What are you likely to keep doing forever? Because that's the most important physical activity, is the one you'll do forever. Link it to friends, social engagement. That's like really important.
Mm-hmm.
And, I always hear, whenever I hear people contact me, like I get a number of people contact me, years after I've seen them, and it's always doing stuff that's cool. It's never about their pain score. It's like, hey, I climbed a mountain, ran a marathon, back playing tennis, playing my kids. I had a guy, he's like, been surfing, went fishing, never dreamt I'd do that. So grateful. You helped me lose my fear. And that's usually what they say. You gave me confidence and you helped me lose my fear. And now I'm doing stuff I love. That's the truth. We get so fixed on pain scores, which really is not. Pain scores are just a barrier to doing the stuff you love. But the key is to do the stuff you love.
Mm-hmm. And I feel like everybody asks about their pain level, but a lot of people don't screen for for all those things that we've been talking about.
Yeah, 100%. Like we have to.
It's not common. I don't think, like, with all this.
It should be.
Yeah, it should be, because if you don't screen for it, how you're going to address it? Like, there is no structured intervention if you're not looking for those things.
Exactly.
To give you like a frame, like to guide you to like what are the things that we have to work that are on the way of rehabbing this person.
Yeah, exactly. Yeah.
And on the lifestyle factors, so if they have trouble sleeping, for example, or like the diet, so do you give like general advice? How do you go about that?
Yeah, good question. So sleep's really individual. So some people, like I saw a chap last week and he can't sleep. And every time he rolls over, he wakes up. And it's like, hey, let's have a look at how you sleep. Let's look at how people have these rules. It's a bit like posture, sit up straight, bend with a straight back, keep your leg, we have these rules of like, you got to hold yourself like this. If you look at when people move in bed, they often move highly protective, very guarded. They're not relaxed. And so teaching people in those situations to, hey, just relax and move in bed is no different to bending and lifting. It's just different threat. So we would teach them relaxation strategies of teaching them to roll in bed in a relaxed way. And that can be so life-changing for people where they don't, even in their subconscious brain, they're protecting their body and guarding their body and tensing their body. And so they're waking up through the night with that. For other people, it may not be a pain problem. It may be other factors like other stress in their life. And we see that as well. So we know that, chronic stress and pain are really commonly connected. And so managing their stress could be the key, or it could be drinking alcohol and coffee late at night. So it's more of a lifestyle habit. So rather than a generic, do this for your sleep, which is often what's done, is to go, hey, tell me why you're not sleeping. What is it? Pain that's waking up? Is it movement around pain? Is it body positions? Is it other stuff in your life? That you have to. So it's targeted and person-centered, rather than saying, just do this and try and get sleep. It's like, teach them relaxation techniques. So I had a young lady yesterday. She's so stressed and she's got neck and upper back pain. And she's like, I get this pain at night. I can't sleep. It's like, hey, let's have a look at what you're doing. And then it opens a whole conversation about what's happening in her life. I'm like, okay, so what do you think you can do to change that? And sometimes it involves bringing in a psychologist to address other major life stresses in someone's life. And that's cool. That's part of our job. It's part of our job is to have that conversation. And I think, PTs historically have felt very comfortable to talk about the body and structure, but not talk about people's lives and their social environment and their beliefs and their feelings. And we have to be good at that because we're dealing with pain, and pain's part of this mix.
Yeah. And like on your experience about the sleep, do you feel it's more often related to stress than like positions?
It's a whole range of stuff. So, if it's people's got, often with back pain, movement is a really big deal, like the way they move in bed and posture themselves in bed. But they'll tell you, patients tell you, like it's not a pain thing. It's stress in my body and stress in my life. It's like, okay, so how do you manage stress? So let's have that conversation. What are your stress management strategies? I drink more alcohol. I'm socially isolated. I'm drinking lots of coffee and I'm on the screen at night. It's like, do you reckon that helps you manage your stress? Probably not. So are you open to change that, trying something different? Because that's not sustainable.
Because I think us as physical therapists, we are a lot more comfortable giving instructions about positioning on the bed, but like when it gets to the area of like managing stress and relaxations, we feel like, we don't feel, I think, as confident on
Correct,
that.
because we haven't been trained. That's why. So there's a massive, we would see that there's this massive gap between the needs of the patient and the competencies and the skills that have been taught to physical therapists. So we think that needs to change, because if we're not addressing the needs of the patient, we need to change what we do. And, we know across societies that we are not adequately addressing the needs of our patients. So we need better skill set. We need a broader skill set. We need more tools in our toolkit, and we need confidence to do that.
Yes. And like when you see like, okay, I did what I could, now it's time to refer, it's out of my scope here. So when you decide at that point?
So it's a great question. So if you think there's serious pathology, of course you would refer. It's like, I'm suspicious this is something else. Of course you refer. So that's number one. We work with a psychologist. So in our practice, we have a psychologist we work with. So instead of saying, I can't help you, go and see the psychologist, we'll say, hey, let's work together. Let's work together. But, so I saw a chap yesterday and he's had a horrendous time history of, chronic and very disabling pain, highly distressing. And he's, I work with him, and he's seeing a psychologist. He's working with a personal trainer, and he's working with me, and he's under the support of his GP as well. That's a team, but we're all supporting that person to reach their goals. And his goals are really clear. Like he's got major anxiety problem that he's addressing. He's highly sensitized. He's, his body's responses to pain are to just go into this massive protective patterns. But he's learning these skills through all of us of like learning to be relaxed in his body, building his confidence to do stuff he loves. He's regularly engaging in physical activity. He's sleeping better. He's more confident because all of those people are working together to support him. And that doesn't often happen in clinical practice. It's like, people don't normally work together. We've got silos of the psychologist is sitting behind the door, and no one knows what's going on there. And the pain doctor's telling them they're this, and they need to get it injected. And the PT's telling them to do something else. Poor patients get so confused.
Yeah. No, for sure. Having a group, it would be the ideal scenario, like to work with. And so, like, for example, those patients, when you see them, they're highly guarded, you know that's going to be really hard. Do you try like a few sessions, and then if you see that it's not going to have a good response, you refer out to the psychologist, or
Yeah, so look, with fear, I think we are the people who psychologists aren't good with fear, like not with pain-related fear, unless they're specifically trained. They're good with dealing with people's, like anxiety, depression, post-traumatic stress. So we see quite a few people who've got PTSD. I had a guy last week who'd been beaten up. He was like road rage, and he was suffering from PTSD. So I'm like, okay, so I'm going to refer him through to the psychologist straight away, because he's getting major flashbacks, and he's got this huge anxiety because he thinks someone's going to beat him up. So that's an immediate referral. I'll work with them, but in tandem. So if someone's profoundly depressed, major anxiety, panic disorder, PTSD, some of those people do really well just activating them, and others you can see within a few sessions are struggling, and that's like, okay, opens that conversation to say, it sounds like you're hitting, these are the things that are the roadblock. Are you open to working with someone else to support that? And people normally are very happy to do that.
Very nice. Okay. And like regarding the diet, so you give like general advice?
Yeah, so the evidence around diet, and I'm very careful on this. Usually it wouldn't be a first discussion point. It's usually, depends. So, if someone is really overweight, and they may have tried lots of diets in their life, another person telling them to go on a diet is not going to help, right? Usually we start with, let's build your confidence. Let's get you changing some behaviors around physical activity and movement and getting confidence in your body. Let's build that up. And usually it then opens of like, right, now what's your next goal? And it usually starts to open up that conversation. So the evidence around diet is pretty strong that, ultra processed foods are shit, like really bad, like sugar drinks, ultra processed food, alcohol. They're the things that are really not good for us because they're pro-inflammatory. People often don't realize they're pro-inflammatory. So that actually they could be making their pain worse. They don't know that. And so that's a really important conversation to have. You don't have to be too crazy about your diet, like vegetables, fruit, protein, not too much carbs, natural fruit. Like, that's a healthy diet. You don't have to go crazy. You don't have to starve yourself, but just shifting the nature of your diet can have a huge impact on people's pain. People don't know that. So it's on us to educate them, not to lecture them, not to make them feel shamed by their diet. But then also if you've got, I can think of people I was saying who are had early life trauma, and they need to address that, and they address their trauma they've not dealt with by binge eating and drinking alcohol. Well, me telling them not to do that is never going to help. Like those eating behaviors are feeding something else, and no amount of me telling them what to do is going to change that. But me demonstrating care and empathy and kindness and support might open a door for them to address those deeper issues in their life.
Yeah. And so for the therapists that would like more information, so like, do you train them, right?
Yeah. So we did this trial last year that was published in the Lancet called the Restore trial, and we trained 18 physiotherapists to deliver this intervention. And we had physios who were like 2 years out to 30 years out, I think. And they said it was like a behavior change intervention themselves. So what we did was first we gave them a knowledge workshop. Then we taught them skills, because you talk about these skills, like how do you communicate with someone and they break down and cry? You go, hey, how's this impacting on your life? And they start crying. And a lot of physios are not comfortable with that. It's like, oh, shit, what am I going to do with that? Like, well, I can't fix this. Yeah, exactly. And so they become uncomfortable, and they make the patient feels uncomfortable, and then they signal that this is not okay, and the patient shuts down, and then it's like it just turns into a train wreck. But we know that acknowledging people's emotions is really therapeutic. Validating people is therapeutic. Them being emotional is therapeutic. We have to be comfortable to sit with that. So, part of the training is around communication, about open, reflective communication, about, rolling with resistance, a behavioral change talk. That's part of the training. And then the second part is around the behavioral experiments, how to do them, how to help people make sense of pain, taking people through that journey. And then the tougher part was what we call the mentoring, where it's like learn a driver. You learn to drive a car, you read a manual, you go, okay, these are the things in the car. Now you got to sit in the car, but you're not there on your own. You're there with a driver. So you're driving the car, and you got two people driving the car together so that you don't go off the road and crash. And so what we do is we work with clinicians. They're working with the patient, and we'll work with them and support them and guide them through that process. And that was the clinicians who went through the trial said that was probably the most rewarding but scary thing themselves. Like they did their own exposure training, and but very rewarding. So we use feedback. We developed a competency checklist to say these are the things we want to see you do when you examine and treat and work with people. And that checklist became like a reflection. And so people couldn't go into the trial until they'd achieved competency. So that's the training that we know works for this kind of approach. But it takes time, and we trained once a month, and then they go away and practice with their patients. They train, they come back and do it again until they reach competency. So we're interested in that model. We think it's a really worked in the Restore trial. And we have a website called restorebackpain.com. I don't know if you've seen it, but it describes the training on it. And we're in the process at the moment of setting up a educational platform which can deliver this, basically, is what we're aiming for. Hopefully it'll be out sometime this year. But we're really interested in supporting, upskilling and supporting clinicians to work more effectively with people who are really disabled with pain. That's our interest.
Yeah. I remember watching a few videos of you like communicating with the patient and like how to communicate like the good example and the bad example. And
Yeah.
Because I feel like we have this huge gap in our education that we need help. Like learn how to deal with that.
Yeah. And no one else is filling that gap. Like psychologists aren't filling that gap. They're frightened of pain just like everyone else is, a lot of them. And so they're comfortable to talk about people's emotions, but not to get them to do scary stuff. Like, so who's going to do that job? We're the perfect profession to do that job.
Yeah, we just need a little more training on that aspect.
Yeah, exactly. But that's our team's interest, is to provide that.
And like, if people are interested, like in going through the training, so how long it takes?
It depends. So it's a bit like, how long did it take for you to get your driver's license? How long did that take?
That's a good question. It's been so many years. We do a few classes. We do theoretical classes and then you driving classes.
Exactly. It's no different. It's like that. Did all your friends get their driver's license at the same time? Or did some get it before others?
Yeah.
Exactly. It's like that. So it's to say, it's not like, oh, you have to do this for 6 months and you'll get your driver's license. It's more like, this is the journey you've got to get to. And some people get their driver's license quicker than others because they will adapt quicker, they learn quicker, they learn differently. So within the Restore trial, it was around 5 or 6 months. But there are some people who took a bit longer and some took a little bit shorter. But you know, it's a bit of a journey. It's a bit like learning to do something new, like driving a car for some people. For others, it's like, oh, this is naturally how I want to work. So it's way easier. It's like they've been doing this, but they just haven't had a framework around it. So it's something we're researching more about at the moment, to go, how much does it take to train a clinician to get to that point? And it may be different in different cultures, different undergraduate training programs, etc. But that's what we're looking at.
It's a skill that you have to develop, right? So it takes time to develop.
It takes time, yeah. And it's, people are like, oh, that's too hard. It's like, well, you know, honestly, like, I trained to do spinal manipulation. I spent hours doing that, literally hundreds of hours. And it's a tool I hardly use now because of my clientele. No one was going, oh, you should just go and do it after one weekend workshop. Like, that idea that you can learn skills within 2 days and apply them, that's just not normal. You don't have a psychologist do a weekend workshop and work with complex cases.
And like, how, so when the therapists are applying those skills, how can, like, you, on that process of training, like you mentioned on the trial, you had, like, you were with them kind of checking that. On the training, do you have something like that? Like, how is that mentoring aspect of the training?
So that's something it's a great question. We're starting another trial where we're doing some online training as well. So we're trialing that to see, we think we can do it. Like, during COVID, we did CFT online. It works well. We work with clinicians online with their patients, so we think we can deliver it online as well. But it's the work, our capacity to do that is our biggest problem with the number of trainers available. But the other thing is training teams of people, we think, is the most sustainable. So, we train people in small groups of like 6 to 8 people, so that you're learning off each other as well. And that builds a community of practice. So that idea of training small groups, we think, creates more sustainable training so that they become the trainers in their own setting.
At some point, do you watch them treating?
Always. No, always, yeah. So that's what we do, is we watch, yeah.
And then can give feedback to, like,
that's the key.
Help them what they're doing wrong.
We don't have a good culture of that in our profession, of literally watching people practice. But that's what we do. So literally, we'll bring in, and we do it within our practice, is we have every Monday we will bring in a new patient. One of the therapists will lead the examination, interview and examination. We'll sit and support them and watch them.
That's very nice.
Yeah, it's done in medicine, it's done in psychology. We just don't have a culture of it in PT. It's crazy. It's absolutely crazy. And there's a lot of anxiety around, oh, you're going to watch me work. It's like, yeah, that's how you learn. And I think, we're not there to criticize people. We're there to support their growth.
It's because it's such a new skill, so like you kind of need the support to make sure you're implementing it right.
Yeah, 100%. You can't do it from a book.
Yeah. And like, would you say that CFT is more like you say like an intervention? Do you feel like it's more like a philosophy or like a tool? Because it feels like it's very comprehensive. Like it's not like I'm gonna do a manual therapy. It's like a whole
it is.
way of approach.
It's a framework, really.
Yeah.
It's a framework. It's a framework that gives an evidence-based understanding of pain, but it's deeply person-centered as well. Like it honors the person's autonomy, it honors their goals and their values. It's highly aligned to the individual. So it's a person-centered approach that's based on evidence and that addresses people. It takes them on a journey to reach the goal. So it's got a lot to talk. You can lever off lots of talks because you got different personalities respond differently to different approaches to communication, even as well.
Mm-hmm.
So that's makes it fun as a clinician, though, because everyone comes with their own unique set of factors and circumstances. It's not a cookie cutter approach.
Yeah, it's almost like a new way to treat.
It is, yeah, and that's what the physio said. The physios who went through the training said it's changed everything about how I work. It's changed how I communicate, changed how I examine, changed how I treat. I treat everyone like this. It's not just back pain, neck pain, shoulder pain, knee pain. It's just how I work. It's a philosophy and an approach that underpins how I work, and that's how I work in my practice. It's deeply rewarding.
And like for the ones that like me right now, I'm thinking, okay, I have the things that I use in my patients. Do you feel like that conflicts with people's like way of treating in the sense of like their tools per se? Or is like in like you can still use, for example, I am MDT trained, I'm Mulligan trained, I do manual therapy. So like do you feel it's something that conflicts or just it's like you are still screening for the same things that you would, like your MDT assessment, your Maitland assessment, or however framework that you follow? Do you feel like you can use both at the same time, or you would like, how do you see that?
Yeah, I do. Look, I think there's an element of both. I think we've massively overcomplicated things. Like I look at how I used to assess people, and I had to go through and do all these things and, lie them on the bed and push on them. And like, I don't think we need to do a lot of that stuff. So there's an element of, I think we've made things too complicated. So this is making it a lot simpler to go, okay, let's just look at the things that people are struggling with, that they're telling us they can't do. Let's assess that rather than going through 20 tests. But it's hands-on. We're touching people, we're testing people. We're checking, we're looking for whether they've got neural sensitivity and neurological deficits, and so we're incorporating all those skills that the things we know are useful. It's almost like, I think as a PT, I had a lot of stuff in my toolkit or my tools in my garage that I really didn't need, but there are key tools that I really needed that I still use. So, I still use my hands all the time because we know that the touch is so powerful as a therapeutic tool. How we use it, though, is something different. If we're lying people on the bed and we're just poking on their back, there's not a lot of empowerment in that. But if we're using touch to facilitate, provide feedback, to motivate, to build confidence in their body, great. And so some of those tools can easily be utilized to do that. That's cool. No problem with that.
because you're still rehabbing them to get them to be back
Exactly.
active.
Yeah. So all your exercise stuff, but I think that probably what we've got rid of is, some of these rules that go with it. Oh, you got to do it like this. You got to engage a muscle like that. It's like, we don't have good evidence for that stuff. We've got to let some of our beliefs go, I think, and realize that they're just beliefs. Some people get upset because, I'll do a full examination and I'm not laid someone on the couch. Well, they never had a couch problem. I don't need to lie someone on a couch if their problem is standing and bending and lifting. I don't need to do that. But if I hadn't done that in my examination, I'd be questioned, why didn't you do that? There's no evidence that helps people. So I think we have to really question ourselves to go, actually, what are the things that are really important here? For example, feeling joint mobility. We're not good at that. We should be really practicing the things we're good at, not the things we're not good at.
And it's almost like we default to the things that we are comfortable with, that we learn.
Right. What we practice. Yeah, that's right. Yeah. And that's why you got to get skilled, confident in different skills.
Yeah. Yeah. Very good. And if people want to learn more about the topic, they got interested, so where they can find more resources.
Go to that website, restorebackpain.com. That'll give you a whole lot of information about the Restore trial, about the training, but also you can leave your name there and you'll get information about when we launch this training platform. And just to let people know, on the training platform, we're going to have there'll be free knowledge on it. There will be like a online paid workshop, which is, interactive. It's got patients. It's got real patients being examined, assessed, and treated with Q&As. It's a very rich learning space. And we've piloted it already, and people really like it. So we are in the process at the moment, because we're self-funding all of this at the moment. We're setting it up as a social enterprise. So we want to use, our interest is not financial. Our interest is to pay for what we do. But then any profits will be used to support people in lower and middle income countries, is what we're aiming for. Because we know those countries have no access to knowledge, or very little access. So that's our mission.
That's awesome. And any advice to the clinicians that now are feeling a little lost?
Look, just hang in there for a couple of months. Maybe 6 to 8 weeks. It's not long. But you can read. We've got lots of material that you can read online, video clips, etc. But we're really interested in supporting clinicians. That's our job. We have a real interest in supporting the people we care for, the clinicians that we support. So, register your interest if this interests you, but also, spend time to listen to your patients. That's so important. I think one of the biggest things that shifts in my career was to actually just change my language and go, hey, tell me your story. And it just changes the whole conversation. Instead of what brings you in today, that's a whole different conversation than tell me your story.
Yes. Very good. So, Pete, if people want to reach out or contact, is that a way they can find you?
Yeah, look, you can. I'm deluged with emails, so they can through my Curtin University email address, which is p.o'sullivan@curtin.edu.au. I will send you some links to some papers. So, we've published a number of papers that are open access now. Just recently published a paper, I don't know if you've seen it, called The Pain Clinician, the competencies that are needed to become a pain clinician, which is really what we've been talking about today. And that was written by, I don't know if you've heard of Stephen Linton. He's a pain psychologist, and Johan Vlein. They developed the fear avoidance model. So I was involved with those guys and another colleague, Hedvig, in Sweden. And we kind of wrote it to go, instead of talking about, oh, this is how PT should work, this is how psychologists should work, the paper is really like, what do we need to train in pain clinicians to better serve our patients? That's a cool paper. So I'll send you links to them as well.
Awesome. Very good. Pete, thank you so much for taking the time to come chat with us today and explain us a little bit more about CFT. So I appreciate it.
That's a pleasure. Nice to talk to you.